kind of weird. So when we look at the trunk muscles, we can group them together a little bit, like where they are and what kind of function that they have. Like we have breathing muscles, for example. We have stomach muscles, for example. We have back muscles, for example. And then in the neck, of course, we start with the neck muscles. When we look at the first muscle, we're looking at the trapezius muscle. And the trapezius muscle is best seen on this model or on a full body model, but you kind of see the outline of from here down and then down in here, and it goes further, just it's cut here, goes downward to the, about T12, the lowest thoracic vertebra, where we still have ribs coming in, and then it goes up on the vertebra into the neck, and makes this, when you do that on both sides, you get this geometric trapeze figure kind of thing back here. So that's trapezius. So that's how you recognize. So if I tag this, it's going to be in here, because that's the best model that I feel like I got here. Then the next muscle that I like a lot on this model is the sternocleidomastoid. And that muscle is a nice word because it's worded by the attachments on the bone. So if you study your bony attachments, you know a lot of those. You know that the sternum, that's the breastbone, right here, that part. You know the clavicle, that's the collarbone. That's right, this part, right here. And you know the mastoid process, we just added in a little quiz, and that's behind the ear right here. And so that muscle goes right here. Or you can actually, what you can do is you can oppose a motion, and you oppose the action, then the muscle has to contract, and you do an isometric contraction, and then the muscle bulges out, and you can feel it. So here you can turn your head, and you can see how the muscle comes out right here, and right here. It actually depends on, you know, the personality in the magazine. You see people, they're just walking around, you see these strings going up and down. And that's the SEM always. And that muscle is crucial for headaches. Gives people a lot of headaches. A lot of blood flow going out of the head goes through that thing. And that's clinical. So sometimes when I have people with headache, and you know, I don't know what, you know, I mean, I do multiple things, but that's one of the things. I check the sternocleidomastoid. There's a lot of trigger points in there. I'm like, maybe we got to do something about it. And we do a little bit and see if it helps. And if it helps, then we do more.
Do you massage?
Oh, yeah. Yeah, I hold the head and I, you know, hold the head like this a little bit. You know, you hold them gentle, and you got to be careful if somebody has trauma in here, strangling, or, you know, then you got to be very sensitive to that. But in my whole time, by the time I'm working the neck and we work on the side, we figure out. And I don't come from here, you know, I go from the side, and then it's like you kind of figure out what to do most of it. And if somebody is very sensitive, because I move the neck and feel like where's the restrictions in the joint motion as well. And by the time we're doing all of that, generally we understand if you can do that or not. But yeah, of course, if somebody's sensitive, no. You always respect the patient's boundaries that way. Because you can't have, if somebody gets anxiety, you can't have healing. You know, so that's number one. That comfort is number one. Anyway, I'm really chatty today. And then the scalenes are the next ones that we have here. And the scalenes are attached to the upper neck on the side and then go into actually the ribs underneath the clavicle. So they actually are these are underneath. And the yellow thing you see here is a nerve. That's the brachial plexus nerve. Yeah, take pictures of these models. Because this is how you learn this stuff. You're not learning it by reading a text. Pictures are way better for this stuff. So that's the scalene. So now we have trapezius here, scalene here, and then the SCM here. So they write these three, we just talked about these three muscles in the front of the neck. And then we go in the back of the neck, but in the back of the neck, I think it gets a little too confusing. Oh well, we still have in the front, we can go one deeper. And we don't really see that here. That's like deep in there. And I do that on patients. I go right on the bone and go, and work right there, if they let me. And very gentle. But if you, the problem with this is, these are the muscles that when you have a whiplash, when your neck goes, you know, a whiplash is when you're sitting in the car or something, and you have your head not on your headrest, and you get hit from behind, and your head goes like, woo! That's the whiplash. So if you have your head on the headrest, your whiplash is way less. Ding, 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 ding. Great place to do the retraction exercise. You know, there's the Saab company, car company, the old days, they don't exist anymore. Their headrest apparently would have a spring in it to move towards your head more. Because of that. I learned that in some biomechanics, trauma, whatever, personal injury seminar things. But it was one of my really good teachers, so I know this stuff is good with him. Anyway, and it's research, it's all research and everything. But these muscles in the front, they are often strained when we have that whiplash motion. And so that's, that's why when we do this postural exercise and stuff also, a lot of the times the front muscles, you are wimpy. They're overstretched, but they're also injured often. Because, we're not meant to have car accidents. We're meant to maybe fall down because we're walking. Not even a bicycle accident. When whatever created us. The problem is evolution is fine, but the brain evolution goes a little faster than the body evolution. And so we didn't have car accidents until, we had, I got into the hospital with this finger. Before 1920, I would be dead. Because I didn't have any penicillin or anything. And so, that's like, if you have to sort of sometimes think about the big picture a little bit, when we think about how the body is created and what the forces are. So that's when this muscle becomes important, and that's why I put it in to the booklet, so you have, if something happens or whatever, you have at least a reference point. And then in the back of the neck, we have these muscles go up and down. And the first layer what we have here is the trapezius, so I leave it at that. I don't go deeper on the testable terms for when it's spinalis splenius. And you know why I don't do it? Honestly, it took me till a few years ago to I really get it. And I've been doing this work since 1990-ish. So I'm like, it's hard stuff. And then I talked to some chiropractic person that I was working with at some point, and it's like, how do you work the pelvis? What works for you? It's like, it's the piriformis. It's like, oh, I forgot about that muscle. I'm like, that's a really important muscle. And so we all do that as technicians. We all are technicians and so. So I put those in because they are important, but I'm not going to test on those. Nor am I testing on these deep ones that are right in the occipital. And these I should test on. These are the coolest little things. They're cut off here. You can't really see them. But they're really deep in here, and they help move the head around. But they also are attached to the eyes and help adjust us to the eyesight what's going on. So there's reflexes in there. That's like when you throw, you notice that you throw a cat into the air. You don't do it, but if a cat falls down somewhere, it usually lands on the feet. It has this reflex where it adjusts here and pulls, and that's when you see that back line that I was talking about before, and it pulls the whole spine and rotates it around, and it happens. This connection with the eyes where they figure out where am I in space, then these react, and then the spine can react to it. So it's very interesting stuff. But that's, more application. I had somebody who was a bad whiplash who broke a windshield with the head and couldn't work anymore and do all that kind of stuff. And I talk about it a few times and working him deep, slow, gentle, deep. Don't just you take yourself 15 minutes to go deep. You got to have some muscle strength. May change his life. I didn't expect it. And that's the relax. There was so much tension in those things because of this torque or this injury or whatever. Muscles are like little babies, I think, sometimes. You can't beat them up and then expect them to always work. So, anyway, but we're not working on the negative, we're working on the positive. So after the back one's there, then we go to the erector spinae muscles. And the erector spinae muscles here is hard to see. They're going up and down. You can see some slivers here going up. But those are really the ones that go up and down the spine and hold the spine upright. And so what they're actually doing is when we bend forward, they're pulling, and that's what one of their function is, to let us not fall down and collapse. Whoops. But to hold us up slowly and slowly go down. So that's one of their functions. And then, of course, moving around a little that way. They're the more superficial, even though you can't see them here. You can see them here if you actually see on the side. You see the cut in there. You see the side view. What's interesting too is the muscles that are like superficial. Most are more associated with motions, and the muscles that are deeper, because the way that they're layered, obviously, it makes sense when you think about it. They're more postural and slow, deeper movement, more isolated motions, and so forth. So that's another thing that I learned over time. Like biomechanically, structurally, you see this is a big pulley system. We talked about the multifidus. From there, I think all we got really left is the intercostals, the breathing muscles, and then the stomach muscles. And so the way that I do those on a test, and the way we structure and look at them is we have the stomach muscles are here. We got 4 layers of stomach muscles. From the outside in, we got a top one that goes up and down. That's a 6-pack. That's the rectus abdominis. And then we got 2 on the side, and those are the obliques. The reason why they're called abdominal obliquus, is because the fiber run in a diagonal fashion. So that's why they're oblique. So we have 2 of them. We have an external and we have an internal abdominal obliquus muscle, if you want to be all whatever. For us, it's just the abdominal obliques, that's fine. So you hear these different ways of pronunciation of these muscles. Generally, it's in your general direction of what it sounds like. So just trust yourself a little bit, and because the Latin terminology is sometimes a little goofy. But anyway, on one side of this model, you can see the white stuff. That's the fascia overlaying the muscles all together here. And then you see the top layer of the muscle. On this side, you have that removed here, and then over here, you have the first layer of muscle also retracted back. So on this side, on the left side here, you see the outermost layer on the abdominal wall, and that's the external abdominal oblique, external abdominal oblique. And then on the other side, you actually can see a little bone right here. So you know there's a little more showing than this side, a deeper one, and that's the internal abdominal oblique on that side. The way you recognize it is the outside, the external ones, the fibers run like you're putting your hand into your pocket. And the inside one, they go the opposite. They don't work that way. All right. So you see how the external one is attached over here at this whole area, more or less, if you really just visually look at it. And then it goes towards the center, towards the midline. And in the body, in the front, we have this thick fascia here in the midline that things can anchor into. And so it holds the content and everything together in this direction. Also, of course, moves us this way forward. And then the internal is attached more here on the cresty part, and on the back it goes upward towards the internal attachment, goes this way. And so it's sort of overlaid. What's interesting is when you test them also, really, I've been just going through these things again, like you test this side, like this is the motion it does. But then the other side does the same motion on the other side. It just pulls it over together. So they are working. It's actually kind of an interesting way of showing it because they're working together. If you look at the motion patterns when they do it. So anyway, but that's how you recognize that. And if you turn this over, underneath you got one that goes across. And that's the transverse abdominis. And that muscle is known to be helpful in the core, making the core strong. Because it it squeezes everything together and just holds all that gut together. And that's really the core, making this stable so when we move our shoulders and our hips, it's not like, whoa, let's move everything all over the place, and that wears everything out faster. And then lastly now, we get to the chest stuff, the breathing stuff. We got 3 muscles there that I wanted to, I did the rectus abdominis, right? Yeah. I got the diaphragm, and I got the internal and external obliques. Intercostal, sorry. So the diaphragm, what you do is this model, look, now you can see. You take all this out. In one piece. And then you see here under the lungs, you see this piece? That's diaphragm. And then you keep going here underneath the lung. That's the diaphragm. That's a muscle. That's like a parachute muscle. See, look at that. When you look at this picture over here. That's that muscle. And so that muscle is all the way up, and the lungs are all the way up. And when that muscle pulls all those lungs from the center down, the lungs inflate because it makes double the room. So that brings air in. That's why we breathe with that muscle. That's why it's very important to try to be doing belly breathing if you can. And we always talk about hold the gut in, but it's a little tricky because oxygen is really important for us, obviously. And so food for thought, right? A little bit. So the diaphragm is really an important muscle. So when we look at it on the model, it's kind of like this thing up here, right? So it goes underneath the lungs, right? Because it wants to pull the lungs down. That's its job. And it's attached in here around the spine. That's all diaphragm, this round stuff. All right? And then, so that's cool. Oh, the heart. Uh-oh. This is a really bad operation.
Oh, wow.
All right. Well, then we're gonna get and finish up with the internal and external intercostals. And so here we put the chest plate back in, and then on this side you see these things coming out here. These fingers coming from behind and attaching these muscles. Those we'll do next week. Those are the serratus anterior. They're holding the shoulder blades against the chest wall. So they're actually really interesting. But we don't look at that side. We look at this side because we take that part away. We remove that top muscle. And then we see here the ribs. You see the ribs? And in between the ribs, we got two muscles. The external intercostal actually pulls the ribs out and up and inhales. So that's this one out here. You can see it's the one that's superficial to the other one. And the internal one is deeper, is underneath. And when that contracts, it actually pulls the top ribs down and collapses the lungs more to forcefully exhale. Like that. And so that's what that one does. All right, so I think that's it. Is that it? Let me say. Big thing. Did you guys pay attention? Well, just the trunk.
Oh, you didn't talk about the linea alba?
The linea alba, yeah, that was this. Okay, yeah, sorry. The linea alba is this fascia on the inside, like here. That sometimes as diastasis recti in childbirth it can split up a little bit and get a hernia. That can be a problem because it's a very strong connection that goes through multiple layers. It goes through different. It creates a deep in and out sort of structure that things can attach to. That's really its purpose, and it's brilliant. You don't have too many of these structures that go that direction, that go deep like that, and things can anchor. We have one in the neck, where we have the nuchal ligament that goes in and out, that things can attach into. That's sort of a structure that goes superficial to deep. Yeah, very few places. Also, the diaphragm is a very specific. We don't have too many muscles that go across like that. Very specific. So the diaphragm, and then we have pelvic floor. So depending, and that's where it gets a little interesting with different therapies. They also look at that kind of stuff because it torques the body around in weird ways. So it's interesting. Anyway, any other structure I missed? Good. If not, I want you guys to go and do a little bit of these terms.